Okay, so I was showing you something else. I wasn't talking about JR at this point.
Okay.
And JR may have been high. But the time he comes in, it's 220, let's say. I gave you that number on purpose. Glucose does tend to act as an osmotic diuretic. It's going to pull more water through the PCT, so that could cause a little bit of a diuresis because it's pulling more water to the PCT. But here's the thing: is that remember the plasma threshold, the Tmax, transport maximum, below 250. So even though it's high, it still gets reabsorbed.
Okay.
So even though you don't see any evidence of glucosuria, it doesn't mean that he doesn't have hyperglycemia.
So we need to know that 250 is that?
Around 250. It's a little bit different for all of us.
Okay.
But the idea is that you can have hyperglycemia and still not spill glucose in the urine. Remember we said that urine glucose is not a good screening test for diabetes? And that's the reason. Now, if you do have glucosuria, it's very specific. You know, it means your sugar's sky high, you probably have diabetes. But the absence of glucosuria doesn't necessarily mean, because it's not that sensitive a test. Okay? So, do you think that, what else is going to be abnormal about his urinalysis? Yeah, he's probably going to have ketones because his cells have been starving. Okay? He's been losing weight. The reason he's losing weight is he's wasting fuel. All that glucose that enters into his bloodstream is being spilled into the urine. So it's not being used to build materials in the body. It's being used to just carry water with it into the urine. So he's starting to undergo ketosis. His triglycerides, his fat is being broken down, and as you break down fat, you form ketones. Do you think his urine is more acidic or more alkaline? Yeah, it's more acidic. Now, it typically tends to be slightly acidic anyway, but if you're forming ketones, it's going to even be more acidic.
So it's going to burn with these?
What's that?
Will it burn with these or just like?
No, if you had an infection, it would. If you had gonorrhea, it would, maybe, or chlamydia.
Can your urine be so acidic that it hurts?
Yeah, so it's.
You know, usually it's not the case. Usually that's not the case. You have to have usually an infection.
So,
Or it doesn't even have to be a bladder infection. It could be a urethral infection.
so like basically the white blood cells is what irritates your.
It's inflammation. You know that with inflammation, you release inflammatory mediators, like even histamine can cause pain. It can cause itching in some locations for pain because it binds the sensory nerve endings for pain. And so it can cause a burning type pain with the pig, but that's related to inflammation. Usually in terms of pH, the tissue is somewhat protected by a mucin that's produced by the transitional cells that line the bladder and the urethra. Y'all remember that the bladder is lined by transitional epithelium?
Yeah, all right. So how are we going to treat it?
How we're going to give fluids. You know, part of it is just giving them volume now. We may, 220 is not that bad. We may give him a little bit of insulin in the ER, bring his sugar down so he stops diuresing. We're going to replace the volume that's lost. We're going to get him back on his diet and send him home. But he could be 2 or 3 liters down. So he's going to be in the ER probably for a couple hours getting IV fluids. All right.
So is that the only two things you would probably see in his urinalysis is the ketones and elevated pH?
He might have, he could have a high specific gravity.
Or I'm sorry, the
That means his urine might be, in the end, a little bit more concentrated if he's volume depleted.
Okay.
But yeah, that's kind of what I would expect to see. Now, if he did have an infection, what would you see?
The pyorrhea.
Which is white blood cells.
Right.
You could see leukocyte esterase in the urine chemistries or nitrites. You would see see on the microscopic, in addition to the pyuria, you can see bacteria. Sometimes you can even see a little bit of hematuria. You know, sometimes a bladder infection will cause erosion of the bladder wall, call it hemorrhagic cystitis. So some people, when they have urinary tract infections, they get blood in the urine. So yeah, that would be expected. Okay. If I ask you to name 5 things that are evaluated by urine chemistries and 5 that are evaluated by microscopic, could you name that? What are 5 chemistries we assess for?
Protein.
Blood, protein, ketones, glucose, bilirubin, urobilinogen, nitrites, leukocyte esterase. And then what would be 5 things you would assess for by microscopic?
Pyuria.
Cells, so white blood cells, red blood cells, bacteria, we said, crystals, anything else? We talk about cast. Cast can be made up of proteins, it can be made up of cells, it can be cellular cast. What happens, or whatever it is, it gets stuck in the renal tubule and takes on that shape prior to being dislodged. Usually, though, it's a reflection of kidney disease, not, for instance, a bladder infection. When you see cast, you know there's something going on upstairs in the kidneys. You might see protozoa, trichomonas. You might see spermatozoa. I'll tell you a sad situation. I saw, and again, this was a nice person, but they had a cocaine habit, and so as a result, they had a cardiomyopathy. And they were very indigent. Their lifestyle wasn't your lifestyle. You know, they lived in a very indigent area. And so, you know, the problem, they had Medicaid, and so one of the problems with having Medicaid is it only provides for about 12 visits per year. If you have a serious medical problem, while the Medicaid will pay for the hospitalization, it doesn't continue to cover doctor visits. So she comes in one day, and she's got a lot of problems. She's got some burning when she urinates and some pelvic pain. And so in the end, we end up doing a pelvic exam and a urinalysis. And her just took a swab from her pelvis and looked at it under a microscope. It's got a wet prep and was full of spermatozoa. And her urine had spermatozoa in it. Okay. And but I didn't see any evidence of infection. So I said, "No, I'm curious." I said, "Have you had sex recently?" And she broke down, and it turns out that she had sex to pay for that office visit. It's kind of a sad situation. Because I thought to myself, you're having all these pelvic problems. Why are you having sex right now? And it was because she wanted to pay for the visit, which made me feel bad. Sometimes you get a chance to see how the other side lives, and it's very depressing. Yeah. Well, you feel bad for people too. You see what people struggle with. Okay. Make sure that with respect to the kidneys, you know how each part of the renal tubule handles filtration. What happens to glucose? We say that the kidneys filter the plasma, but it also then processes that filtrate. And various solutes are handled differently. Let's take glucose. if I ask a question like, how is glucose handled by the kidneys? And I put A, it's filtered. Let's say B, it's secreted. C, it's reabsorbed. D, both A and C. Or E, all of the above. What would the answer be?
So it's A and C.
It's A and C. Right. Glucose is fully filtered. In most cases, it's 100% reabsorbed, but it's not secreted. If it was secreted, then lots of people would have glucosuria. Now, what are the two solutes within the blood that are used to monitor renal function?
Oh,
Okay, B1 and creatinine. So if you admit someone to the hospital and you do a chemistry profile and their B1 and creatinine are high, that reflects renal insufficiency. Now, and I'm going to just go to this because we mentioned this. There's true renal insufficiency and there's pre-renal insufficiency. We don't use this term pre-renal insufficiency. We call it pre-renal azotemia. So if someone has a true renal problem, okay, that interferes with filtration, their B1 and creatinine are going to climb. If someone's kidneys are normal, but let's say they're in shock and they're not delivering enough blood flow to the kidneys, well, that's going to impair filtration. Their B1 and creatinine will climb. But in this case, it's pre-renal azotemia. Azotemia means an increase in nitrogen. So in this case, it's pre-renal azotemia. It's not due to the fact that there's any problem with the kidney. It's the fact that we're not sending enough blood flow to the kidneys to be filtered. So it's allowing those waste products to climb. If we just take these people and correct that problem, then B1 and creatinine come right back down. Whereas someone with a true kidney problem, their B1 and creatinine progressively climb over time.
so I'm sorry, you said the creatinine would equate to nitrogen?
Well, the B1 is blood urea nitrogen. So when we say azotemia, we're talking about an elevation in urea or nitrogen. Or nitrogenous waste products. Okay. If I ask this question, as filtrate ascends the ascending limb of the loop of Henle, does osmolarity increase or decrease? You have to, in this case, question
No,
like
it's
this,
It's decreased.
it's going to decrease, right? It decreases because you're holding on to water.
Right.
You're reabsorbing salt, but you're holding on to water, so it decreases. When you get one of these questions with respect to renal tubules, avoid the tendency to jump on it. Kind of think it through. No, we all have that tendency, for me. But it's one of those things that'll bite you because you have to kind of then think about it again or think all the way through. Now, the opposite would be true with respect to the thin descending limb. As filtrate moves down that thin descending limb,
Right, because the water's in the
water gets reabsorbed, but solute doesn't, so osmolarity increases. Now, what part of the kidney serves as the target for ADH? Well, that's its origin.
Right.
But what is it target? What part of the kidney? ADH. What is it? Not ADH.
And the collecting duct in the DCT?
Yeah, it's actually the late distal convoluted tubule and collecting duct. When it binds to receptors within those two structures, it triggers it. It's like one of those signal transduction pathways. It leads to the production of those proteins which serve as aquaporins, channels for water. So it allows reabsorption of water. Whereas aldosterone binds to those same two tissues, DCT and collecting duct, but it triggers production of pumps, those sodium potassium ATPase pumps.
But they both serve to decrease osmolarity, right? Or is it?
Well, no,
they're opposite?
they both serve to increase reabsorption of salt water.
Right.
Aldosterone pulls in salt, but if the aquaporins are there, water's going to follow.
Right.
And usually the same stimuli that trigger release of aldosterone trigger release of ADH.
Right.
So usually those aquaporins are there.
So that if they were elevated, they would both be.
Yeah, usually if one's elevated, the other is. Usually, not, there's some exceptions, but usually. Okay, make sure you know what each segment of the renal tubule, what type of epithelium it has. Do the cells of the ascending limb of the loop, do they have microvilli? This is a trick question. They have some microvilli, but it doesn't form a brush border. The reason that you have a brush border in PCT is because there's so much absorption. That's the majority of the absorption occurs there.
You said that was the ascending limb that has some.
Yes, ascending limb. You know, with regard to the clinical scenarios, make sure you know all of those. Remember I gave you that table of how you would think the pH would change, or the ACO2 or the biopar with the various acid-base disturbances with and without compensation. Just make sure you can reproduce that. And it would be better, instead of just memorizing it, if you do it from your head by thinking through it.